It's really a privilege and an honor to be here and to be asked to talk today for our residency programs. I was actually just notified this morning that my program director at NYU is retiring after 19 years. He was an amazing program director, and I really appreciate everything that he gave me and hope that I can do him proud for the rest of my career, because he just really instilled in us this love of surgery and also of passing it on. So Dr. Berman in New York, thank you. In any event, we'll get started. I don't have any disclosures. This is my sleep stress management recovery and coaching certification. Obviously sort of minor compared to the rest of my training, but did give me some additional information.
Yeah, just what plan back.
So if everyone can, oh, thanks. So anyway, these are the objectives. We're going to understand the basics of sleep, what the types are, cycles and processes, recognize the problems associated with short sleep and circadian dysregulation and how this applies to overnight call and nocturnus schedules, all of which we suffer from. Be able to evaluate information from sleep trackers. There are a lot of wearables these days, and most people have some kind of wearable device. Even if you don't realize it, you probably do. For instance, the Apple Watch can monitor your sleep through the Apple Health app. So even if you don't realize you have it, you probably have a sleep tracker. And then learn and reinforce environmental and behavioral strategies to support sleep. As I talked about, or as I should say, the introduction talked about, I really believe that there is a requirement from both sides. So this resilience concept, just so you understand where I'm coming from on this, the resilience concept, I think sometimes is overused for individuals. So I'm today really coaching on an individual basis, but please understand that when I coach for other groups, for instance, I just gave this talk to the medical executive committee for the hospital, I focused on systematic change. Because individual resilience only exists in a scenario where we have boundaries that are set by the system. Because if we all don't work together, we can see what happened during COVID. COVID was an opportunity for us all to understand the limits of the system, and we all went to the limit, we went beyond it, and then we were asked to continue going without a lot of reflection or ability to recover. So I think what that experience should have taught us, and I hope that we can establish a new normal, is that we have to work together, both from an individual and a systems perspective. So today is individual coaching, but please don't think that I think that's all of it. It's not all of it at all. And as you grow and mature in your practices and become part of leadership, it becomes incumbent upon you to also set expectations for your team. And that can start as early as a second-year resident for an intern, or as an intern for a medical student. Okay, so it don't have to wait until you're the chief. That's what we all sort of have this feeling that we all have to wait and wait and wait, because you're all waiting for the next thing, for fellowship, for the first job, for the second job, for the chairmanship, that sort of stuff. It all can start today. And we all have more personal agency than I think we understand. Surgical residency, or any kind of residency, I should say, kind of beats that out of you, but we all have personal agency. So I want to just talk about the coaching process and how I come about this. So for me, I am an endurance athlete. I have done 2 Ironmans, not at this level, at the very pedestrian personal best level of sub 14 hours. But this is one of the world champions. He was known to be a pain in the neck, but he had a lot of good quotes. And one of them is, he said, success in triathlon is above all else the ability to endure suffering. Is there any better description of residency for anyone, no matter what residency you're in? It is an ability to endure suffering. And that's true at all for medical education. It starts when you're in college and you're trying to take the MCATs and you're trying to get into med school. It's a long process, and there's always some suffering and sacrifice involved. And anyone who doesn't understand that doesn't understand the field of medicine. So medicine is an endurance sport with infinitely higher stakes because there are patients' lives on the line. I have taken the lessons back from endurance sports, which is we first define the demand. We're going to talk about what is the demand that you're placed under and how can we respond to that. So this is Christian Blumenfeld. He is the reigning world Olympic champion. That may change after Paris this summer. And also you can see that he is not a shredded, emaciated athlete, and he single-handedly has turned the world of endurance sports and body image on its head, which is why I like to use him as an example. But in any event, this is the demand of this race that he was doing here, which was running 18K after an 80K bike. This is what happened to him on the run, both in Edmonton and then again at the US Open in Milwaukee. He was cramping, and a lot of it was because he was in this time trial position, which is forward. You can see a very aggressive position for those of you who ride bikes. So that was a gap that he had. He was cramping. So how do we address this gap? Well, they clarified his bike fit, and really the thing is he just needed more time in the time trial position and also some mobility exercises for his hip extension. So he was educated and he was coached based on the gap and the demand. And then he went and won the PTO Asian Open, as well as every other thing there is to win in triathlon. So we want to define the demand, we want to identify the gaps, and then we want to provide coaching that fill those gaps that can get you for the demand so you can perform the best. So that's how I come at coaching from this sports background. So first, we're going to talk about the performance demand of being a doctor. Now, usually I tailor this to surgeons, but this is for everyone here. And so I'm going to show you some surgical data because that's one of the literature that I'm most familiar with. But I've taken some slides out of this section because I want to hear from you what your demand is. Okay. So this is a study that was performed in 2011. And I actually participated in this study because I was a resident at the time in the lab. Or no, just back from the lab. So this is a study of all residents taking the ABSITE, the surgical in-trauma training exam, and I'm sure everyone has their own version of this enjoyable experience every January. In 2010, there were 6,200 categorical residents. They had greater than a 95 response rate because they were captive audience. We all had to sit there and take this time, and I don't know who would decline taking this. And so they were looking to find what their sleep time was, and then there were some other things, views about faculty supervision and views about education time. But for the purposes of this talk, I'm focusing on what they told us were our sleep time, and I should say our, because I participated in this. So for the type of shift for extended call, which we all know is the more than 24-hour call, which now is the 30-hour max or somewhere in that range, daily hours of sleep, people got less than 3 hours. So that is a type of sleep debt that's acute. Okay, so you're sleeping less than 7 hours. 7 hours is the definition of short sleep, which we'll come to in a minute. But so less than 3 hours acute sleep debt. Night float, they got less than 3 hours. What happens on night float? You're against your circadian rhythm, so that's circadian disruption. And then on a day assignment, they got maybe 5 hours or more. So that's chronic. And then on the day off, they maybe got 7. Hopefully they got more. But again, short sleep is 7. So what you're seeing here is if you put all these things together over time, the minimum residency for most people is 3. Some people, some of us was 8. That's acute on chronic with some circadian disruption sprinkled in. It's unpleasant over time. And the older you get, the more it loads up on you. Then you'll hear me talking to the residents, like if you stay late with me in a case from some of my big cases, I will not let the resident come in early in the morning. I absolutely will not. And their chief residents will fight me on it. But it's a good opportunity for the intern to step up and round on the service, and we have to model this behavior. It's not because I want you to go home and get a beer, it's because I want you to go home and get some sleep so you can perform. But every time that you do this, every time that you have short sleep, you are contributing to a chronic sleep debt that's very difficult to recover from. So I just want to back up and now give, so that's what I see from the surgical perspective. I'm sure this is true across residencies, but I want to just get a sense of how much people feel they're sleeping. So on 24-hour call, is anyone sleeping at all? Okay, I'm seeing some nods. Okay, Kyle's saying no. Anyone get any sleep? Sometimes you might get some sleep, right? What might you get? Maybe an hour. And is that restful sleep? No. Why is it not restful? You get paged during it. What else happens? You're checking your pager, right? Because you're terrified you're going to miss a page, right? And then there's the worst scenario, which is called sleep inertia, where you fall asleep and then you answer the page and you don't remember what you said. So I'm sure that's happened to everyone in the room because you're that tired, okay? So not restful sleep. And so I'm hearing no sleep on 24-hour call or maybe an hour and not restful. Is there anybody who actually gets sleep at night regularly in this room? And actually, next time you speak, if you can just tell me what residency program you're from so I can also sort of make some comments. So anybody get any more than an hour regularly on 24-hour call? No. Oh, yeah.
Family medicine.
Family medicine? Mike, and that's family medicine, where we might think that you might get more sleep because there are less things happening at night. Doesn't sound like that's true for you. Okay, so very good to realize that. So he might get 2 or 3 hours, might. Okay, and how long is your residency? 3 years. Okay, that's still a very long time to have that kind of sleep debt. Okay, let's talk about night float. So the whole point of night float is to not sleep, right? Okay, so how unpleasant is night float? Does anyone enjoy night float? Okay, there's no one who's saying no. Why do you think night float is so terrible? Because it is, I think it's terrible. Anyone? Why is it terrible? And residency program? Internal medicine. So disruption of your circadian rhythm, yes. So, and then what happens, so one, you're disrupted from your circadian rhythm. What does it also do to your personal life? You don't see your friends and family, and I'm sure this is particularly difficult if you have children. Or being a caregiver for anyone, and I should make that distinction because a lot of us are caregivers for elderly family now, or pets. Some of us have 3 dogs who don't believe that sleeping is a thing. So in any event, so that's why circadian disruption. So no matter how many strategies I'm going to give you for night float, it's still just not very good, because unless you become a monk, and I'm going to show you some data, like where all you do is go to work and come home and you don't have any personal commitments at all, which is not the lived experience of anyone in this room, I'm sure. Everyone is caretaking for someone, even if that's just yourself. You can't really have any kind of social connection. And how much social connection do you need to be a human being? I mean, everyone varies in the need, but you need some. So that's I think the biggest problem with night float is the loss of social connection in addition to your circadian disruption. Then when you're on the day shift, let's just say you're working a regular day. How does that go for you? How much sleep do you feel like you get? 7 or more residency program. Radiology, okay. Anyone else? 4 hours. So what's making you get less sleep on the day shift? You have a son. Okay, so you have caregiving obligations. Yes, how old is your child? 3, so hard, and probably even harder if you have a baby and you're really, then your circadian disruption is even more, okay? And that's a whole nother thing about having children. This is something we've always told you, you should delay childbearing. The fertility data is concerning for women, particularly in surgery, and this does not help the sleep disruption. So I don't have a huge amount of data on fertility today, but I do think it's something that we need to think about. And family planning is a very important subject for residents, and it should be allowed to be talked about. Anybody else think that they get more than 4 hours? I know radiology, and this is just not saying all radiology residents get 7 hours, but he is saying he gets 7 on the day shift, which I'm glad about. Anybody else? What do you think? We've got 4 and we've got 7. Anybody in between? 6. What program? Internal medicine. Okay. Is anybody tracking their sleep in the room?
Yeah.
Okay, you are. What method are you using? You have a Whoop. Okay, great. I have a Whoop too. Anybody using an Oura ring? Okay, that's mainly an endurance athlete nerd. Okay. Anybody using their Apple Watch? Okay, so there are some people nodding because the Apple Watch does have a function for that, although you have to kind of add to it, but okay. And then on your day off, how much are you sleeping? More than 7 hours. Does anybody have a number that you think? This is a very important point. 9. Okay. Anybody else? More than 9? No. You getting less? And why are you getting less? Kids at home. So that's the thing. On your day off, you may have other caregiving obligations, or you may want to, I don't know, do something for yourself. So you may not be able to catch up on sleep. But unfortunately, sometimes on our days off, we have to sleep bank. That's a term I'm going to talk with later, or like sort of fill the sleep debt. Okay, there's a sign in the surgery residency room, which I find highly distressing, that said I've slept for 24 hours without medication on multiple occasions. I don't know where that came from. Do you know where it came from, Kyle? I don't know who put that up, but I do find that a little distressing. But so hopefully we're not sleeping 24 hours on our day off, but you may be sleep banking or catching up on sleep debt. Is there anything in the chat? Okay, and feel free to put something in the chat.
This is a nice one.
Oh, thank you.
Hello, everyone. It's beautiful handwriting.
I think we're not needed anymore.
Yeah.
Okay.
I like your
All right,
tone.
so I'm gonna, guys, someone is not muted, if you don't mind. Thank you. And also, please, for the participants who are on Zoom, please feel free to use the chat because they can let me know about the chat. Okay, I don't want it to be limited discussion to only be limited to those in person. I think in this day and age, we really have to get used to the Zoom format because this is how we can have more control over our personal time. Okay, so the more we get used to using Zoom, the more you can be at home and like put a load of laundry in. I know this sounds crazy, but these are the ways that you manage your time and you can focus on your nutrition and your sleep is by using technology. So we all have to get very good at Zoom. So please feel free to use the chat. So this is an article that was published in JACS, the Journal of American College of Surgeons, in 2019, and I use this because one of our surgeons actually contributed to this. It was Dr. Weinberg, and this was a study of 19 acute care trauma surgeons using the Whoop, which is an early model fitness tracker that our radiology resident and I share. And what they showed here is that on their pre-call day, these surgeons were getting about 6 hours of sleep. And the reason why I have the 7 circled is because remember, that's the definition of short sleep. So the first thing that jumps out at you from this graph is what? Like, I find this graph disturbing. What is it? No one's getting 7 hours of sleep. So right away, this is a huge problem, right? So not a single surgeon in this study, 19 surgeons, busy trauma surgeons, are getting the recommended amount of sleep by the CDC, which is 7 hours. And that doesn't even describe the quality of their sleep, just hours. And so on pre-call days, they got 6.4. On a post-call day 1, they got 7. Then on a post-call day 2, they got 6. And then on post-call day 3, they got 6.6. But what we learned from this study was that really baseline sleep recovery does not occur until post-call day 3. That has implications, and I've actually seen that in my own personal data, which I'm not going to show today because I wanted this to be more of a community talk, but I have replicated that in my own WHOOP data. And when I publish my sleep paper, I'll have my own data in it. But what does that tell us about scheduling call shifts? What is the minimum cadence we should be doing? Q3 is my opinion. This isn't borne out in large studies, but I do think that this is an area of opportunity for investigation. But, you know, the old days of every other night call, or when we can sleep when we're dead, that's really what destroyed people. But I think Q3 is the bare minimum. How do people feel about the cadence of your call shifts? Do you see a difference between Q3, which everybody is on Q3 at some point because of vacation and big other schedules, and Q5 or Q4? Can anyone speak to how they feel subjectively between Q3, Q4, Q5? Okay, what do you think is the difference?
I feel that I sleep better.
Okay, you sleep better on Q5. Yeah, probably because you're getting less interruptions. Anyone else feel that way? Does anyone feel good on Q3? Anyone want to volunteer for Q3? Okay. No. All right. So that's our demand right now. Is there anybody who has a different schedule? Is there anybody who takes no call? Let's go back to demand for a second. Is there anyone in this room who takes no call at all? Okay. So that's the key here is everybody in residency is taking some call. You may get to a point in your future life where you're not taking so much call. Like, I don't know, maybe some of the less acute specialties may not have such overnight disruption, but I'm sure for family medicine, you still have to cover a practice, and radiology, someone's going to have to take night coverage. So somewhere, so I don't really know of a huge, does anyone know of a field where, or maybe PM&R, which is an awesome field, but maybe they don't have night obligations if they're not, I don't know. Does anyone know of a field that doesn't have overnight call long-term? Well, okay, dermatology. They have Stevens Johnson. Someone gets Stevens Johnson. But yes, dermatology is probably the best one. Anybody else know of a field that we have here?
Radiology.
Okay, so okay. So radiology, it sounds like you might have an opportunity to control your schedule not to have call. Anyone else think of anything? That's definitely not an option in surgery unless you do very smaller surgeries. But I can't really think of it. So this is going to be something that's going to be with you for your life and something you need to manage for your life. Okay, so let's talk about the gap. So what is the problem with we can sleep when we're dead? So one, this whole sort of macho 1950s, this all generated from Halstead's, there's actually an interesting paper on this from how this was generated from Hopkins. So please remember that the Hopkins pyramidal system that started all of medical residency in the United States, Dr. Halstead, although he was a brilliant surgeon, he was a morphine and opiate addict. So it's very important to remember that our entire residency pyramidal program is based on drug abuse. And I say that with all due respect to Dr. Halstead, but it's something that we need to recognize and acknowledge about how we're training people. So the problem with we can sleep when we're dead is it interrupts our circadian rhythm. It can create or accelerate health problems. I'm going to show you data on that. And it limits our most important recovery tool. So when I was an NIH fellow, we had to give like little talks about our hobbies before our big research talks. And I had to give multiple of them because I was there for a while. And I would always give them on ridiculous endurance things. And so you can, which are still laughed about, but you can talk about every recovery tool, like the boots and the massage guns and all the things in the world, but the most important recovery tool is sleep. It's just a foundational thing that you don't need any tools for, you just need to sleep. So who has poor sleep? I don't know how well this projects. This is a slide from the CDC, but this is showing prevalence of short sleep among US adults in 2020. And overall, the take home here is one, that short sleep was defined less than 7 hours for adults, and that 36% of people who are 25 to 44 years have short sleep. So I'm using that demographic because I think that fits our residency demographic the most. And you can imagine if we did this specifically for physicians in training, what this would be like 90%, right? It would be much, much higher if we stratified out by profession. And then I'm sure if you had children and caregiving obligations, it's even worse. So I just want to, this is a key point. Anytime you see this key point here, just this is a major takeaway. But so for acute and chronic sleep deprivation, acute sleep loss is being awake for more than 16 hours. And obviously we do that often on our overnight call shifts. Chronic sleep loss, not getting more than 7 hours of sleep for a 24-hour period for multiple days. Obviously we do that quite a bit. And then circadian misalignment, being awake when the circadian system is promoting sleep, or trying to sleep when the circadian system is promoting wakefulness. And I'll show you that in a moment. So again, acute, chronic, and circadian misalignment, which we all suffer from. So the impact of acute sleep deprivation on individual performance is less controversial. Individual performance, patient outcome is more controversial, and I'll show you that in a moment. This is the famous study from 2005 in which they compared residents after heavy night call to alcohol ingestion. And they showed that the hours awake correlated to these blood alcohol concentrations. And these are also studies about number of accidents that residents got into. So if you're very tired, another plea, please don't drive. Please use Lyft, please use Uber, because there are good data about how sleep deprivation can lead to crashes. So this is a review paper that was published in the Journal of Occupational Medicine. It's a while ago, but still I thought it was useful. They reviewed all English language studies since 1984 of sleep deprivation and house staff performance. And they concluded that reported effects vary based on specialty. As expected, the surgical studies most frequently showed the little effect of sleep deprivation because of what we think in surgery, that we are superhuman and that the rules don't apply to us. However, all studies since 1990 support the hypothesis that sleep deprivation impairs performance. So the question, though, is if there's an impairment on performance, does it translate to patient outcomes? And that is much more difficult to prove. So what we see here is this is the major study that came out after the work hour. So as everyone may remember, Libby Zion changed the rules. There was a case in New York about work hour restriction where a patient suffered an adverse outcome. There was a Bell Commission. If you may remember, this all was going on when I was resident from 2004 to 2012, or just before I started residency, I should say. The major finding of the Bell Commission, which is ignored, was actually that residents need more supervision. And ironically, unfortunately, what came out of the Bell Commission was work hour restriction, which is not wrong in itself, but it limited resident supervision. So the entire point of the Bell Commission was, in my opinion, not very helpful because we took people out of the hospital and we limited more, we put people more on their own with larger lists of patients. So they compared extended call shifts, max 30 hours, to capped call shifts, what was going on when the really rigid work hour restriction came out before we got a little more flexibility with max of 16 hours. And they showed that they were equivalent and there was no difference in outcome. Now, this was published in the New England Journal, but this was done by surgeons at Harvard, so one has to wonder if there was some bias in it. But I think it sort of more goes to show you that it's very hard to show an impact on patient outcome because there are so many of us, and it's sort of having more people, more eyes on a patient. There are safeguards to some extent. However, this paper was published in 2009, a very small study, but it was they were looking at risk of complications by attending physician after performing nighttime procedures, and they did show an increased rate of complications in surgeons that slept less than 6 hours. But the problem with all of these studies is everyone usually has a point to prove going into it, so it's a little more difficult to interpret these. So what's the impact of chronic sleep, poor sleep on health? It's across all body functions. Hopefully this projects, but basically I'm using from Healthline to just show you that it goes through everything. Memory issues, trouble with thinking and concentration, accidents, which we just spoke about, the data is very clear on that. High blood pressure, weight gain, risk of heart disease, low sex drive, risk for diabetes, weakened immunity, and mood changes. And there is also an impact on fertility. So the consequences of circadian misalignment, these also have all of these findings, okay? And then they also showed reported menstrual irregularities, dysmenorrhea, and difficulties with pregnancy. What can happen with sleep deprivation and mood is we can have decreased emotional empathy and depression. How many people at the end of a call shift, you just want to get home, there's a patient who's being difficult for whatever reason, they're probably going through something terrible, but we are less empathetic than we could be because we are just so tired we need to go to sleep. There's so much sleep pressure. And you know, and then that sort of sets up this negative cycle of feeling guilty. But a lot of it is, remember, the system is not allowing you to be your best self. So the whole point of this talk is to try to figure out how we can incorporate coaching tools into our practice so that we can try to be our best selves, despite being in this system, which it is very difficult to completely change. The patients get sick at night, we have to somehow be able to attend to that. I want to bring this up, and again, every time I show this slide, I do want to remind people that there is support within the Alliance. If this slide brings up concerns for you, please feel free to reach out to your program director, to me directly, and to anyone within the Alliance. This is just an important paper that was published in 2011. It was about 7,900 surgeons. Again, this is a survey, so there's going to be survey bias, which is the thought that the more people who respond are going to respond positively who feel this way. And it's not a true representation, but this is a very, this sort of a landmark paper, still referred to today. And what they saw was that the factors that were independently associated with suicidal ideation the previous 12 months was screening positive for depression. So then the correlation is if we're more tired and we're more depressed, we could be more at risk for suicidal ideation. It's a lot of correlation, but nonetheless, something to consider. And then the question is, how much education do we give you on fatigue? This is a 1 year mandated lecture 1 hour mandated lecture that you get once a year. So the concern is, how much sleep education are you getting in medical education, both undergraduate and graduate? And this is very similar to the nutrition literature, and I have showed this in the nutrition talks. There's basically no education. We just expect you to go out and eat well and sleep well and figure out how to tell your patients how to eat well and sleep well. We can't really do that if we're not educating you. So I'm going to do my best in our 1 hour talk today, but remember, I am not a sleep expert, and we do have BNI here. So I think we have a lot of opportunity to improve our undergraduate and graduate medical education on sleep and nutrition and movement. But this paper, which was published in 2000, showed how much education that medical education was getting. It was 2.1 hours in an undergraduate and 4.8 hours in graduate medical education, which I still think is very interesting because I didn't get any. Did anyone get any formal sleep education other than any talks that I've given in your undergraduate or your graduate medical education? Anyone? No. Okay, so I have talked to Dr. Cohen about this. I think this is an amazing opportunity. Creighton, I think, has an opportunity here to really leverage our resources on the campus to maybe provide some sleep education. Again, in addition to this 1 hour mandated talk. The barriers cited in this paper was lack of time in the medical curriculum and need for better resources in teaching facilities. Well, we have great resources. We have BNI, and we have teaching facilities. That building is absolutely beautiful at Creighton. So I don't think that's our issue. The lack of time in the medical curriculum, my point is, well, how can we afford not to provide this education? We have to consider the health of our physician workforce. So that to me is a very concerning barrier, because do we need to spend all that time on biochemistry in the preclinical years? Does anyone use their biochemistry in their daily clinical practice in this room? No. Okay. So this I thought was a very interesting, I felt like Dr. I don't actually know how to pronounce her last name, so I'm not going to try, but she is at Texas Tech and has done a lot of stuff on trying to change call schedules to make it more physiologically helpful. And so she published this in the Journal of Surgery News in 2021, where she said that overall, I do not think surgeons on 24-hour call are hurting patients, but I do think surgeons compensate for their exhaustion and hurt themselves, so their patients don't pay the price. How many people feel like they have done something that has been at their own expense to take care of a patient when they've been tired? Every hand in this room should go up, because I'm sure every single person in this room has done that, and everyone on Zoom, because that's what we're told we need to do. And the nurses do it too. The thought process is that the nurses, every single person who touches patients in the hospital is gonna help, because that's why we did this. That's our mission, but it is at the expense of ourselves. And I really want to encourage you that we have to figure out how to have a balance. So this is now going to be our education and coaching. So we know what our demand is. We know what our gaps are. Our gaps are, these are the things we do. This is how we're sleeping now, and we don't know anything about sleep. So I'm going to try to provide you a little bit of information about sleep, but remember, this is very high level overview. We're going to talk about REM and non-REM sleep cycles, and the two-process model of sleep and circadian rhythm. So REM sleep doesn't really define in stages, whereas non-REM is. This is where you dream. It's characterized by rapid eye movements, muscle twitches, and cardiopulmonary irregularities. So this is really more towards the end of the sleep cycle. Non-REM sleep has these 4 stages. The first one is when you're just falling asleep and you still have a low threshold to wake up. That's stage 1. Stage 2, and I'm going to show you an EEG, but basically you need a little bit more stimulus to wake up. This is about 10 to 25 minutes. And then stage 3, you're in more slow wave activity. And then number 4, you're in higher slow wave, but a lot slow wave activity. But a lot of people just combine 3 and 4. But basically I would think of it as sort of like you're going down into sleep. And then the higher you go in the stage, the deeper you are in sleep. So light sleep is 1 and 2, 3 and 4 is deep sleep. And I missed an end parentheses there. So here is, this is from a textbook on sleep. This is kind of sleep textbook seems like the Bible. So you can see the up top, the alpha waves of when you're relaxed, but you're awake. Stage 1, you're starting to fall. That's where you're in that high stimulus to, or low stimulus to wake up and you're just starting to fall asleep. Stage 2, you're getting a little bit deeper and you may have this K complex. And then in stage 3, you are in deep sleep and that's where you have these delta waves. And then in REM, it's sort of this lower baseline on the EEG. I just show this to you in case you ever see this, just so you have some idea of the stages of sleep. So just to summarize that, so REM, or rapid eye movement, I should have made that, is 25% of your sleep time. There are no stages. This is when you're dreaming and memory is consolidated. So how important is this in medical school? Very important. And as a learner now, even as a resident and a staff, I learn things all the time still as a staff, you know, like one of my residents just looked something up on, or talked to pharmacy about one medication that made the patient's mouth dry. It was helpful because it's a medication I use all the time for urinary dysfunction after pelvic surgery. So I'd like to be able to consolidate that in my memory tonight after she spent the time talking to pharmacy. So I'd like to get some REM sleep tonight to make sure I remember that. So you can think of that as your brain is activated, but you're paralyzed. And this is more later in the night. So those of you who get up at 4 a.m. to work out, you are cutting off your REM sleep. And I've actually, most people know I used to get up at 4. I don't anymore. I get up at 5 because I really felt like I was like cutting my sleep short over a period of time and it just wasn't worth it. Non-REM sleep, 75% of your sleep. Stages are 1 to 4. Remember, 1 and 2 are light, 2 and 3 and 4 are deep. Minimal or fragmented mental activity. You are going to have a relatively inactive brain, but a movable body. And this is more earlier in the night. The way it works is we have cycles. So you're going to first sleep cycle is 70 to 110 minutes. You go to light sleep, deep sleep, and then you're in REM. Okay, so light, deep, REM. And then as you progress through the night, and that first sleep cycle is usually about 90 minutes, and that's called an ultradian cycle. And some people actually think you work best during the day on a 90-minute. Like a lot of people in the productivity world like to talk about this ultradian cycle and that you should do 90 minutes and then take a break and then do 90 minutes if you're really focused on deep work, because you're sort of set up for this cycle. So you can see here in the first cycle, it's the longest. And then as you go through the second, third, fourth, and fifth, you're sort of getting rid of your deep sleep and you're getting into your REM sleep. But you need both. Okay. So again, the 4 a.m. wake up, not ideal if, like, you know, if you're not somebody who normally, there are different chronotypes and some people actually normally wake up at 4, but they're pretty limited. And so you're cutting off some of your REM sleep if you're getting up every day at 4 a.m. and that's not your chronotype. So again, more deep earlier in the evening and more REM later in the night. So what does it look like average? So this is the average WHOOP member sleep. Now I'm going to show you some sleep tracking data and the WHOOP isn't apparently that great, but actually this isn't far off ideal. And this is a healthy young man. So most of the endurance literature and most of the literature in the world is on men. This is a big issue in endurance sports right now that we need to include women in the talk because women are not small men. And that's also true in medicine, is that we need to have more women in the conversation for research. But here, the WHOOP actually showed 10% awake, 24% REM, and then the rest deep between light and the 1 and 2 and 3 and 4. They're really not that far off. So a healthy young 18-year-old male is only awake 5% of the time and has a little bit larger sleep, deep sleep. So I actually took from this that I didn't think the WHOOP was that terrible, although the data that I'm going to show you showed it to be a little bit worse. But so that's what healthy sleep is looking like. So if you're finding your sleep tracker is telling you that you're 30% awake, either your sleep tracker is not very good, which is a high value, or maybe you need to be considering how you can get more restful sleep. So these are the various sleep trackers. WHOOP is the one that I use just because I just find it the easiest to look at my heart rate variability, resting heart rate, and sleep data every day. But a lot of people use the Aura ring, which is the ring here. It's not very convenient for those of us who have to scrub all the time, so that's why I use a WHOOP. And then the Apple Watch, you do have to kind of download an app, so it is a thing, but you can do it. And then this is a Fitbit. So there are just any times of them. So this is a paper from 2020 that looked at the sleep tracker data. And they basically said that your total sleep time, your total wake time, and your sleep efficiency are relatively accurate, but not very accurate at sleep stages. But I still think that means you can get quite a lot of information from this. So if you're concerned about your sleep and you want to do something more objective, which is not necessarily needed, and sometimes gets this sort of unhealthy obsession, much like calorie tracking can be a little bit obsessive for nutrition. But if you're somebody who wants to look at the data, this is an option. You can at least get your total sleep time and your sleep efficiency, which is how long you're awake or asleep when you should be asleep. So best try, Fitbit Ionic was the best one. It's been recalled. The Aura Smart Ring was next, and then the Whoop. I think the Whoop is great. I've used it for years. It actually tells me when I'm sick before I know it. So so I do personally use it because I've had it helps me avoid overtraining. So, but in any event. All right, so what happens to our sleep cycles when we have acute sleep deprivation? This top panel is the baseline sleep, and this is inverted from the one I showed you earlier, just because I thought the one I showed you earlier was a better graphic, but this is the one straight out of the textbook. So the first recovery night after 38 hours without sleep, so after your extended call shift, what happens? So you can see that your stage 4 sleep is increased, and that first cycle is delayed, is longer. Your first REM episode is delayed. So when I presented this to the surgery residents, one of the surgery residents who did use a sleep tracker had said she had noticed this post-call. And one of the subjective things that she told us, she was, of course, our administrative chief resident and completed every assignment and told everyone to do assignments. She was amazing. But she it brought all the assignments in. And she said she noticed when she was on post-call, she didn't dream as much. Does anyone else notice that? So that's what's happening, is you're not getting, as your first REM episode is delayed, you may get less. So that's the stages of sleep. Now I want to talk about circadian disruption. So this is also a key point here, okay? So the key point for the last one was just REM, dreaming, non-REM, not dreaming. And then REM happens later in the night, deep sleep happens earlier in the night. Here, we're going to talk about our circadian rhythm and our sleep drive and our wake drive. So the sleep drive is considered process S, the wake drive is process C. So process S is dependent on your sleep and waking. It's your sleep debt, and it's actually mediated by adenosine, which caffeine can mediate. So that's where your caffeine comes in here. And the principal marker of this is slow wave sleep or deep sleep for the non-REM, stage 3 and 4. Process C is your wake drive, and this is not dependent on the sleep and waking, it's clock-like. This is dependent on light, temperature, and melatonin. So this is really, getting daylight is important here. So when you look at when S and C are synchronized, so you're on the day shift, you haven't taken night call in a while, let's say you've been on vacation, you're synchronized, hopefully. So your wakefulness and your sleep pressure are together. So as the longer you are awake, you develop more sleep pressure, you fall asleep, and then this all starts again. Everything is synchronized. You get your sleep, and then the pressure to wake up starts again. Okay. The thing I want to point out here is that this is from a NIOSH. There's a long training for nurses who work the night shift. This is like a big training on the NIOSH website. There is no such training for doctors. I don't know why. So what happens when you're desynchronized? So what happens when you're on night float? And you're doing your best to stay synchronized, but it's very, very difficult because there's so much pressure. Well, you'll get home from your post-call, and hopefully you've worn sunglasses to decrease the light, but we all sometimes forget. So now you've gone home and you've gotten a lot of daylight, and you've woken up your brain. But you have so much sleep pressure that you still fall asleep. But now you're off because you have had that circadian disruption, and now the wakefulness pressure wakes you up, and you and sort of crosses your sleep pressure, and so you wake up. You're desynchronized. And so now not only are you getting this, you're getting the circadian dysregulation is causing your short sleep. And this will continue until you can try to synchronize a little bit. So the mediators for circadian organization is light is the biggest one. It goes in through the retinohypothalamic tract, gets to your suprachiasmatic nucleus in the hypothalamus, which live in the optic chiasm. All of these little clocks, the blue ones, are targets for I can't even pronounce it, I'm not a neurosurgery resident, but anyway, you can see here that there are systemic behavioral and environmental cues that act on these clocks, and it's hormones, temperature, and feeding. So that's why eating at night actually it disrupts your circadian rhythm. These are all things that try to keep you on a schedule. Temperature is a big one, and these are things that you can manipulate. That's why I'm pointing them out. We can't really manipulate our hormones, but we can manipulate temperature and feeding or fasting. And circadian behavior and physiology, cognition, mood, brain homeostasis up here is what the effects of this is on here on the physiology. And down here, what are some end targets of all of these mediators? Is blood pressure, blood glucose and triglycerides, and xenobiotic clearance in your kidney. But main thing is you can see how the end here, blood pressure, is mediated to some extent through circadian dysregulation or circadian regulation. So I want to show you the circadian rhythms of hormone, temperature, and alertness, because this is something that we can manipulate. So it goes from 6 a.m. to midnight to 6 a.m. again here. So the first one is you can see at late evening, your temperature is rising, and then it's going to start to fall. Okay, so this is something that's very important in Phoenix when it's 120 degrees out, and why it is so important actually to modulate the temperature in your house at night. It's very hard to sleep when it's hot, so just something to be aware of. And I particularly have concerns for this, given that residents often want to save money because we're not being paid very much. And I personally did this as well. And so you keep the thermostat up very high. And I understand that's also important for climate change, but at the same time, we're not sleeping. So this is a very important mediator. I just read that at the Paris Games, they're actually not going to have air conditioning. They're going to have Olympic Games. They're going to have some kind of non-air conditioning temperature control to keep it less than 78. So I'm really interested to read more about that as part of France's plan. In any event, melatonin peaks at midnight and comes down. So a lot of people talk about taking melatonin. What happens if you take exogenous melatonin? Remember your endocrinology. Yeah, so you're going to suppress your own melatonin. So I'm not a huge believer in supplements, and you won't see me doing any coaching on supplements. Okay, and that's because I think supplements is something you come to after you've exhausted all of the simple behavioral changes and environmental changes. Early morning cortisol starts to rise, you can see here, and then it comes down by midnight, by midnight here, excuse me. And then finally at noon, you're most alert. And then it starts to wane in the afternoon. So you can see how your sugar crash in the afternoon, if it's going to correspond with your alertness and your cortisol. So we often are dragging by the end of the day. A lot of this is just hormonal. Okay. So again, temperature is highest at the late evening, comes down overnight. Melatonin is highest and then comes down as you sleep. Okay. Early morning cortisol is highest in the morning and comes down, and then your alertness is highest at noon. These are just your general body circadian rhythms and important targets for manipulation, and also just to understand how your body works so that you can recognize it on call. So what happens on the night shift? Well, these things get sort of dysregulated, obviously. And you can see here on the day shift and then on the night shift, what you're seeing on between the day shift and the night shift is a small modulation in the hormones and temperature, but not a huge one, because your body just cannot change very easily to the circadian regulation. So just a flattening of your melatonin, a slight, flattening of your cortisol, but so you can see that you're not really changing. So you're still fighting those pressures at night to stay awake because your body has not been able to change very much from a hormonal and temperature situation. So both the central and peripheral clocks are resistant to adaptation from the day to night schedule. It takes a long time to adapt. There's variability in your ability to adapt, and not everyone can adapt. And without specific interventions, only 25% of workers show circadian adaptation to night work. And I am not aware of any systemic interventions that have been tried with physicians. And the largest rate of adaptations, this is my favorite one, have been reported in offshore oil rig workers with isolated work environments. So these are people who go work on an oil rig, they leave all their caregiving and other responsibilities at home, and they are able to adapt because they can make these changes. But that is not the lived experience of any single one of us in this room, particularly if you have any kind of caregiving obligation. So that was very depressing. And so it sounds like, is there no way to fix this? Well, there is, to some extent. It's just, you have to be meticulous about your sleep. Much like I always talk about being meticulous to some extent about nutrition, but I think you have to be even more meticulous about your sleep in this environment if you want to be a high performer. And all of us do. By definition, if you're in this room, you want to be a high performer because you've made it this far. There's no way to get to this point without being a high performer. So how do we do this? Well, we have to set a foundation of good sleep habits to minimize our chronic sleep debt. We have to recover from extended shifts and acute sleep drift, and we have to minimize the effects of the nocturnist schedule. And you may be able to manipulate your schedule so that you don't have to do a night float situation. Like I will never do a night float again because I just could not at all. But you know, in residency, you're required to do it, mostly because of work hour restriction. But long-term, if it works for you, that's great. There are some people who find it really works for them, but you may be able to control your schedule to not have to do that. But you're probably still gonna have some element of overnight call and interrupted sleep. That I think is much harder to completely get rid of. So what are the domains that we can manipulate for healthy sleep and to minimize our chronic sleep debt? So start at time, your sleep space, your routine, caffeine, food, alcohol, and your phone and your pager. Okay, so let's first talk about time. Does anyone here have a sleep schedule that they adhere to? Yeah, Dr. Chandra does, and attending. Is there a resident in the room who has a sleep schedule? Okay, why? So the residents know if you text me after 7, I'm gonna get kind of annoyed unless the patient's dying. In all seriousness, surgery residents know that. Why? Because I have a sleep schedule and I am in bed by 8 o'clock every night because I get up at 5. And I used to get up at 4, but so I start shutting the house down. I have a routine. I have a reminder on my phone that prompts me to start shutting the house down. The TV is off. I try not to do screens, although I read, so it's on a screen, but I have a routine and that really helps me. And I encourage you to try to do that. And try to stick to the schedule. Go to bed and wake up at the same time each day as much as possible. That's very hard in residency, especially when you need to sleep bank or catch up, but it is something to consider. And the biggest way you can mediate this is the weekends. So everybody should go out and enjoy themselves on the weekends, but the days of the 4 a.m. partying is probably not a good idea anymore if you want to perform well. Everybody was going to do it once in a while, but I think on a regular basis, we need to move past that and try to continue to have a sleep routine on the weekends. And how many hours do we want a night? 7. Remember, 7, less than 7 is short sleep. Okay. So our sleep space, has anyone put intentional thought into where you sleep in the room? Everybody's probably thought about it a little bit. Like, first of all, you want it to be a place that you enjoy. It's not your call room. You know, you want your bedding to be comfortable. You want it to be dark. You want to keep it to be cool. Temperature is one of the biggest things here. The important thing here in the summer, what do we need to do in the summer for Phoenix for managing, especially if we're on the night float system? What do you need to do with your sleep space? Blackout curtains, exactly. What else? Temperature, I would try and make sure, you know, it's not a time to have the thermostat at 80. And then also maybe even white noise, especially like for Manhattan residents, you need some white noise. Okay, and then there are all these, you know, the other thing is to try not to do work in the bedroom. You know, it's very, especially I often have the laptop next to the bedside, especially if I have somebody that I'm worried is leaking. I have the laptop next to the bed to check the CAT scan as soon as it's up. That is not a way to encourage your brain to sleep. What you're doing is you're trying to train your brain to sleep. I understand sometimes it's necessary and I'm not going to really change that practice, but you know, it's best to not do that. If you can leave your phone outside of the room. I often have a Kindle to try to read on the Kindle and not read on my phone to encourage myself to not get bogged down in social media or texting or anything like that. Is really try to read on a screen. And you just want to make sure you, as much as you can, your sleep bedroom is for sleep and sex, not for work. Try to keep the laptop out of there. And then this is the routine that we were just talking about. Teach your brain that it's time to sleep. And these are all things that you can do. Warm shower is a good one because it actually cools your body off. Your body works to cool off. Gentle yoga, meditation, breathing, warm tea, whatever it is for you. For me, it's reading fiction, but for whatever it is for you, try to do that every night to give yourself, I mean, I worked yesterday from 5 a.m. to 8 p.m. And I took a 5-minute break at lunch to walk around the building, and I had 3 end-of-life conversations and multiple difficult consent conversations. It took me a while to wind down last night. It was at least an hour, and Dr. Patel and I talk about this all the time. So really try to have a routine, especially like, you know, as a resident, that pager, I mean, how many times is it going off a day, especially when you're a junior? And to the point where you have like a startle reflex, you know, but really trying to like give your brain an opportunity. You're not answering the page constantly, but the potassium is 3.8. So really try to give yourself some space from that phone call. Okay. So this is one of the biggest levers you can pull is caffeine, food, and alcohol. So you want to avoid alcohol in large meals within 3 hours of sleep because you're asking your GI system, particularly for food, to continue revving up your metabolism to because there there is a metabolic cost to digestion. It's called the thermic effect of food. So you want to try to not do that within 3 hours of sleeping. Also, you can get a lot of GERD from that. So just these are things that we should try to avoid. Alcohol. What happens when that's a whole talk in itself that I'm planning on giving for surgery residency, but what happens when we drink alcohol? Anyone? Bad sleep, right. So it gets you to sleep, but you wake up a lot. So it's a whole talk in itself, but it's something to avoid. Particularly like endurance athletes are probably not drinking at all anymore. I've stopped drinking completely because I think it's a performance inhibitor. So it's just something to consider. Again, you don't have to completely stop drinking, but I do think it is something to consider in the context of high performance. And then caffeine. Within 8 hours of sleep time is really the best to try to avoid it. I have a rule, it's not allowed after noon. After 12, sometimes I go to 12:30, but I really try to adhere to that as well, so I'm not revved up by my geriatric bedside by 8 o'clock. Okay, this is one of the ones that's most difficult as an attending. As a resident, I think you can control this more, so it's a good practice to get into now. Is that, so for one, every phone has a blue light blocking function. It's not perfect, but it helps allow like not suppress your melatonin. You can put it on your iPhone. I think you can do it on your Android, but you just set it. I set it for 5 p.m. so that I already have a blue blocking, and you can also get blue blocking glasses. It is not ideal. It's really better just to have no light, but it is something that you can do. You want to dim the screen to as low as possible in the evening. But for what you can do as residents, I've noticed the residents on our services are getting better about forwarding tiger texts if they're not on call. And I think internal medicine's been doing that, and I think that's great. So if you're not on call, just do not disturb. Okay, and then turn your pagers off if you're not on call. Our administrative chief resident is not a good role model, so all the surgery residents who do not do what Dr. Kinahan does. I appreciate his ownership, but he won't turn the thing off. You got to turn it off at some point to be able to get some sleep, because you want to be able to perform. You got to let everybody else who's in the hospital do their job while you are sleeping, and then vice versa. Okay. Does anybody have a communication strategy that they use now? Does anybody use the do not disturb function or a sleep schedule on the iPhone or on the Android? Dr. Moss does. I'm seeing some residents. There's something really to investigate with your phone. Okay. So how can we manage extended shifts in treating acute sleep debt? Well, for one thing, naps. Naps are a whole thing, but you can, the best thing that I can recommend is trying to get a short nap after your shift, but not sleeping for 8 hours, because then you're going to have circadian dysregulation problems. So sleep enough so that you can be functional, to interact with your family, to have enjoyable personal time, but then to be able to try to sleep, get back on your sleep schedule as soon as possible. I think that is the best thing to do. And there's not a lot of research in this area. These are major opportunities for research, but the Walter Reed Army Institute of Research would like you to know that there is no such thing as too much sleep. And this is for special warfare or special operators, but we are kind of special operators. The more sleep you bank, the greater the benefits. This is what I'm talking about, sleep banking, where you sleep in advance of starting a night shift, or you sleep in advance of a call, but consider trying to get extra sleep before and after the call shift. That's not being lazy. That is replenishing your sleep tank or sleep banking. And then again, expect it to take 2 to 3 days to recover fully. So again, try to make your call shifts every third night or more. So if you are tempted to be every other night because you want to go for that big vacation, and if your residency program allows it, try to remember that that may not be awesome for you in the long term. You have to remember that this is a marathon, not a sprint. And all of us are probably going to be working until we're 60. What you do now does have an effect at that point. All right, so night float. I think this is the toughest thing because it's short term, but for time, try to maintain at least 7 hours of sleep per 24-hour cycle. I think this is very difficult on night float because of the circadian pressure. I showed you how difficult it is to adapt. There are no real specific interventions. I'm trying to give you some. Sleep bank is needed. Certainly before you start, try to sleep bank. And then try to catch up afterwards, which I think there always needs to be a day off before and after night float to be able to catch up from a systems perspective. Keep it dark and cool. You can use low doses of caffeine, and the best time to do that is between 12:20 and 1:20 a.m. because it's farther away from when you're going to sleep. And especially do that in the beginning of the block, trying to get you onto the night shift. And then when you drive home in the morning, and ER physicians do this a lot, if you make sure you wear sunglasses driving home. You don't want all the light in suppressing your melatonin. This is an important book. The Audible version of it, I think, is almost unlistenable because like the voice who's reading it. But this is kind of the best lay press if you want to read more about sleep and really get into it. Is Matthew Walker's book called Why We Sleep. So this is available on Amazon. That is basically all I have for you today. Just wanted to make sure where we were. But anyway, that's where we are. I'll put up the QR code so everybody can sign in. And I just want to finish right on time. I just want to give everybody any opportunities for questions or comments or any strategies that you think would be particularly useful, or more importantly, how you think residency programs could be a little bit more sleep friendly, because these are all things that we should think about. Any comments from anybody? Is there anything people feel like they took from today that they can incorporate into their routine that's useful? People are nodding, but I'm not hearing anything. You want to use your words? Okay. Dr. Patel.
I think, it's a great talk, right? Things which we normally just ignore. People think a lot about nutrition and exercise, but sleep is not part of that ritual. So one thing I take away is I do need to look into analyzing my sleep. I mean, I try and stick to a schedule, but it doesn't happen. But I need to analyze what's happening. We have the tools now with all the data coming through. We should be using these tools.
So Dr. Patel is saying that he feels like he should analyze his sleep so he knows how to approach it to improve it, and that this is also something that is not considered as well as a nutrition practice or a movement practice. I think this is the foundational practice. You can eat, probably if you ate McDonald's, you'd be okay if you slept. I don't advocate that, but really sleeping is the most important thing that you can do. Any other ideas about anything that you can incorporate or want to incorporate or want to try?
I like the recommendation to wear sunglasses on the way home from call.
Okay.
Because it is often difficult.
Okay, so wearing sunglasses and driving home from call, these are just simple things that you can incorporate today into your practice. Anyone else? Yeah.
I read something interesting a while ago about how we're so focused on setting an alarm clock to wake up,
Mhm.
not to go to sleep. And you can actually get yourself to buy into it. It can help.
Yeah, so that's a great point. He's saying that people are so focused on setting an alarm clock to wake up but not to sleep. And I actually don't need an alarm clock anymore because I do have a sleep alarm. I've been doing it for probably 5 years now, and I wake up every morning basically between 4:45 and 5, and including on the weekends. I sometimes don't get out of bed right away, but it has helped a lot to have the reminder that it's time to go to bed. Because especially if you have kids, or you have other caregiving obligations, or you want 5 minutes for yourself, you don't want to get home and then have to be like, oh God, I gotta go to bed. But unfortunately, that is something we have to consider. Yeah.
Point, sleep procrastination is something that people will do because they didn't have 5 minutes.
Yes. Right. So sleep
They're on
procrastination.
Instagram or TikTok for like an hour.
Yep. Well, and there's also probably some brain chemistry going on with scrolling social media, but I think, it sort of puts your brain on hold, but I think you'll be better served with sleeping than being on social media, especially because there's comparison is the thief of joy. The older I get, the less I want to be on social media and seeing everyone's six pack, because that's all that it is in the endurance athlete world. That's all people want to show you. So comparison is the thief of joy. Anything that you think your residency could do better and that you'd like to talk to your program director about? It's okay to bring it up. I think the only way we have positive change is if we're constructive and trying to figure out an environment where we can all exist in a high performance way that also that emphasizes our humanity, that we are just like patients. We have to sleep too. So even if you don't want to say it here, I want you to think about it and see if there are changes that can be made. They don't have to be huge, but small changes that you can institute within your residency that can focus on your health as well. Everybody matters. The patients matter, but so do we. The only way we take care of them is when we take care of ourselves.